right, so our first talk in this session, the quality of common surgical procedures at critical access hospitals among pediatric patients. This will be presented by Dr. Vanessa Niba, General Surgery House Officer at the University of Michigan.
Thank you guys for the opportunity to present our work. I have no disclosures. Approximately 20% of U.S. children reside in rural communities where they face significant barriers accessing timely and appropriate surgical care. While all communities are currently facing provider shortages, rural communities are specifically vulnerable given the fact that only 10% of U.S. general surgeons currently practice within their communities. And when you combine that with restricted financial budgets and increased pressures towards regional consolidation and conversion, we've noticed a significant increase in the number of rural hospitals that have closed over the past 20 years. Critical access hospitals are federally designated hospitals that provide 24-hour inpatient care to rural communities, and in exchange they receive enhanced federal funding to maintain their clinical operations and to help prevent these closures that have been occurring. And as you can assume with any federal funding project, there's been increased scrutiny over the quality of care that's been provided within these institutions, and we see critical papers that have been published over the past 10 years investigating the quality of medical and surgical care provided at critical access hospitals. Unfortunately, these studies are significantly limited to the fact that they only include adult Medicare populations, and given the fact that approximately 20% of our kids receive care at critical access hospitals, it is important that we investigate how the quality of surgical care for critical access for common pediatric surgical conditions compare between critical access hospitals and non-critical access hospitals. So we performed a cross-sectional retrospective study where we identified children less than 18 years old and younger who underwent appendectomy or cholecystectomy within the HCUP state inpatient database. We specifically chose these two procedures because they're common, frequently performed general surgery procedures that are done by both general and pediatric surgeons. We then separated our cohort into patients who underwent care at a critical access hospital versus a non-critical access hospital. And utilizing multivariable logistic regression analyses, we compared the rates of any complication, a serious complication, an unplanned procedure, and then the inpatient length of stay, after controlling for model covariates such as age, sex, race, ethnicity, and the presence of complex comorbid conditions as a marker of the medical comorbidities. Our total surgical cohort included a little over 42,000 patients, where the predominant procedure performed was an appendectomy. When we look at the patient demographics of kids who are taking care of critical access hospitals versus non-critical access hospitals, the first thing that we see is that very few percentage of our pediatric patients actually receive care at these institutions. But the patients that do receive care at these institutions, we see that they happen to be of an older age group. They were more likely to be white or Native American, and they actually had fewer medical comorbidities as measured by their CCC. And then interestingly enough, these children actually received care closer to home and had to travel approximately 50% of the travel time compared to kids who received their care at a non-critical access hospital. When we compare the hospital characteristics, what we see is that, surprise, surprise, critical access hospitals deal with fewer resources. They have higher nurse to patient ratios, fewer PICU beds, and even fewer pediatric inpatient beds. After risk adjusting in our model, we realized that for critical access hospitals, the outcomes were significantly different from those of non-critical access hospitals. We see that critical access hospitals had lower rates of any complication, lower rates of a serious complication, fewer unplanned procedures, and of course, something very important to a lot of healthcare administrators, they spent fewer time in the hospital after they received their procedure. So our study had three principal findings. Very few children currently receive their surgical care at a critical access hospital. But for those who do get care, they're receiving high quality care and they have fewer post-operative complications. And I think very critically important to our families, they don't have to travel as far to get their surgical care. Taken together, these findings suggest that we have a key opportunity to right-size the delivery of care, specifically to our rural pediatric patients, especially when we consider for some kids who may be older with less medical complexity. Excuse me. I wanted to thank you guys, and I open the floor to any questions.
We'll open to questions.
Thank you very much for this work. It's really important that you're doing. Did you look at complication by age at all? In other words, is there any difference in the 0 to 5-year-old versus 5 to 10, 10 to 15?
We did not stratify by age, but that's something that we're consequently doing in our next iteration of the study.
Yeah, hi, Doug Barnhart from Salt Lake City. We have the opportunity to practice at both a Quaternary Children's Hospital and out in a rural area of Montana in our group, so we see both of these populations. I just had there's obviously selection bias in who gets sent, and I would just ask you whether you actually think a more accurate conclusion is that adolescent patients can be safely cared for in a critical access hospital, because I would just caution that it seems like, given the small sample size and what you told us about the demographics, there's very few small children that are cared for in a critical access hospital. And to come out with a conclusion that you can expand it to younger children, I actually don't think you have data that shows that.
I 100% agree with your statement. I think when we were looking at the age group categorizations, we see that for the 14 and over age group, it seems like that's the predominant population cared for at critical access hospitals. And while I think there are more studies that need to be performed that kind of stratify these specific age groups, I think it's a great opportunity for APSA to kind of look into the which groups are best cared for within the community close to home versus those that need to be transferred to a quaternary center for further care.
If I may, I have a small methodologic question. There's the potential for complication crossover. Someone at a critical access hospital then presenting at a non-critical access hospital for complications. And so you showed us different rates, in fact, quite optimistic rates from the critical care access hospital. Have you accounted for the possibility that you're simply missing those and that they're presenting elsewhere?
Yeah, there's, within the state inpatient database, you do have the idea of who gets transferred to an outside institution. You just don't know what institution that they got transferred to. We did see that there are only about 2% of our critical access cohort that ended up getting transferred to a different institution for the receipt of their care.
Thank you.
Thank you, guys.
Our next paper is entitled Quantifying Recovery Time After Common Pediatric Surgical Procedures, to be presented by Dr. Reynolds.
Good afternoon, and thank you all for being here. For the next 5 minutes, I hope you all humor me and take off your surgeon hats, or I guess I should say scrub caps, and put on your parent hats. I assume many of you in the audience have children. Ambulatory surgery is increasingly common in pediatrics, and we know that it is safe. And as a result, we rely on our families to facilitate an efficient and safe return and recovery for their child. Counseling these families with respect to common questions such as, when will my child return to school? When will they be back to normal? When will I return to work? Are all counseled based on anecdotal evidence. And anecdotal evidence can be great and helpful, but for trainees who don't have anecdotal experience, it would be great to point to the literature and say, in our experience, after X surgery, we anticipate that if things go as planned, your child might miss Y number days of school. And so we set out to do a very simple descriptive study and quantify these recovery metrics with the ultimate goal of improving the perioperative experience for our families. At our institution, these commonly performed operations are followed up by a telephone call in 2 to 4 weeks, and we modified this telephone call to include the following questions. What postoperative day did your child return to school? When did they return to baseline? When did they stop taking pain medications? What postoperative day did you, the parent, return to work? And we had data from about 2 years with this information for the procedures listed here. In total, 192 follow-up encounters had completed questionnaires. The average age child was 8. Most were ASA class 1, and the most commonly performed surgery was an appendectomy for uncomplicated appendicitis. There are no differences in demographics across these operations. And interestingly, despite having different procedures, there were no statistically different changes between the respective variables that we obtained. And put more simply, parents tend to return to work between postoperative day 1 and 2. Their children are stopping pain medications around postoperative day 2 to 3. but interestingly, are not reported to return to baseline until postoperative day 4 to 5, and not returning to school until postoperative day 6 to 8. And we recognize this is a pretty simplistic view of what could be complicated variables, and we're using this preliminary survey data to get more granular information and refine our questions. And I think these questions are ripe for inclusion in a national database. In summary, the children in our cohort missed a predictable amount of school, which might be more than we had anticipated, and we hope this data-driven counseling will improve our partnership with families. In particular, I think counseling families to include and continue pain medications until their child is back to baseline may in turn help facilitate an earlier return to school. And a little side hope is that, as you all know, paperwork is a part of surgery we all have to deal with, and getting these work and school excuse notes right the first time may prevent a phone call and having to do it again. And so we hope this might also help improve our clinic efficiency. Of course, I have to thank the clinic staff who helped collect this data and perform all these follow-up phone calls, and I'm happy to answer any questions.
This paper is open for questions. And if I don't see anyone at the microphone, I appreciate your work a great deal. A lot of work has been gone on into ERAS, and I'm not sure how well the recovery, has been defined, so I appreciate you unpacking that and showing us it broken down a little bit. To me, appendectomy is a bit of an outlier. It's an unplanned procedure, and it's one with a heterogeneous inpatient trajectory. Some people might stay a week or longer. Did you account for that in any way? Was there a large skew in that particular subpopulation?
We only included patients who had simple appendicitis, who had only one pre- or postoperative day hospitalization, and that was just mostly because either they came in at night and the surgery was scheduled for the next day, or they had surgery late in the evening and were discharged the next morning. But we do have data for the complicated appendicitis kids, and that would be another interesting group to look at.
I'm wondering if you could comment a little bit on when the education is done. We've started to undergo a shift in our institute. We have usually a couple of supracondylar fractures and appendectomies that are going to be going to the operating room and going home. And so our preoperative nursing is actually doing our postoperative counseling. They go over cast care and how to use the crutches before the kid goes to the operating room, before we send them home. Mm-hmm. So I was wondering, did you look at all at the timing of when the education was done, or would that be something you would be looking to in the future?
That would be a great additional factor to look at in the future. Most of the counseling for planned procedures, of course, happens in the preoperative visit, but for cases like appendicitis, we could be more intentional about our discharge counseling.
I have one more question. So were the families provided any sort of baseline guidelines about what was expected about restrictions and return to school and those things, and did that match with what actually happened?
That would be a great follow-on prospective study to compare preoperative expectations and postoperative outcomes. We don't have that at the moment.
Thank you very much.
Thank you.
Our next paper is Neonatal Renal Replacement Therapy Patterns and Associated Outcomes in a Novel Cohort with Prenatally Diagnosed Renal Failure, to be presented by Dr. Catherine McDermott.
Thank you for the opportunity to present our work. I'll be discussing off-label use of hemofiltration and hemodialysis therapies in neonates, but we have no other disclosures. Neonatal kidney failure requiring renal replacement therapy, or RRT, has an estimated incidence of 6 to 7 cases per 100,000 US neonates. And about half of these are related to congenital anomalies of the kidney and urinary tract. Early outcomes in this population are poor, but patients who successfully achieve chronic dialysis have good 2 to 3 year survival. Peritoneal dialysis, or PD, is the gold standard renal replacement therapy, but it's hard to initiate PD in neonates. Technically challenging, risks of leak and peritonitis are high, and achieving the ideal 14-day interval between catheter placement and initiation of PD often isn't feasible. Extracorporeal renal replacement therapies, or ERRT, including aquapheresis or continuous veno-venous hemofiltration or dialysis, like PD, are still technically and clinically challenging, but unlike PD, they don't require lag time between access and RRT initiation. Using ERRT as a temporizing measure to allow for PD catheter site healing has several theoretical benefits, improving fluid status, nutritional optimization, but ERRT as a bridge to PD in neonates is not well studied. We had two primary aims. First, we wanted to describe patterns of renal replacement therapy in neonates with congenital kidney failure, and second, to explore associations of first-line renal replacement modality with clinical outcomes and renal replacement therapy-related complications. We performed a retrospective cohort study of neonates in the renal anhydramnios fetal therapy RAFT trial from 2019 to 2024. Details of the RAFT trial are beyond the scope of this presentation, but it generated a novel cohort of neonates with severe congenital kidney disease who were observed prospectively from birth. Our primary exposure was initial RRT modality, specifically the use of ERRT as a first start renal replacement therapy. We defined PD as any installation of dialysate intended for therapeutic purposes, so not just flushes to maintain catheter patency. Our primary outcome was survival to discharge on PD, and secondary outcomes included timing of access and RRT initiation, and major RRT access-related complications, which is the composite of peritonitis, CLABSI, or operative catheter exchange or revision. We performed standard descriptive statistics and multivariable logistic and Poisson regressions adjusted for sex, gestational age, birth weight, and primary renal diagnosis. Of 47 live births, 32 neonates initiated renal replacement therapy. The final analytic cohort was 28% female, with a mean gestational age of 33.5 weeks and a mean birth weight just over 2 kilograms. 44% of the sample had bilateral renal agenesis, and 56% had other etiologies of fetal renal failure. 47% of these patients had ERRT as the first renal replacement therapy modality, and baseline characteristics did not differ between the ERRT first and PD first groups. This diagram shows initial access type, RRT modalities received, and final disposition, and the thickness of each line corresponds to the number of patients who followed a given trajectory. And what I want you to take away from the slide is that there is a ton of heterogeneity in both the initial management and the clinical courses of these neonates. The median age at first access creation was 1 day of life and did not differ by initial RRT modality. But ERRT first patients started renal replacement significantly earlier, 2.5 days of life versus 10 days of life. And among the ERRT first patients who underwent a PD catheter replacement, they had significantly longer times from placement to initiation of PD. And importantly, 80% of the ERRT first patients were able to wait 14 days or longer from catheter replacement to initiation of PD passes, compared to only 35% in the PD first group. Survival to discharge on PD was 53% in the entire cohort and was not significantly different by initial RRT modality. After adjusting for baseline characteristics, ERRT first was associated with more than 2.7 times odds of survival to discharge on PD, but this difference was not significant and the confidence intervals were very wide. Complications were common, and the median rate per catheter month was 0.33, so approximately 1 complication for every 3 months a catheter was in place. This rate was lower in the ERRT first group, but not significantly. And in adjusted analyses, ERRT was associated with a 50% lower incidence rate of major complications, but again, not statistically significant. We were limited by small sample size. It was difficult to separate center-level variation in practices from true confounding by indication, and it's unclear if our findings are generalizable to older infants, to neonates with other etiologies of kidney failure, or to other settings. But our results suggest that ERRT-first strategies for neonates with kidney failure may allow for earlier initiation of RRT and longer PD catheter healing times. The trends we found toward fewer complications and higher survival to discharge clearly need confirmation in larger studies, but ultimately prospective studies are probably required to understand the true risk-benefit and potential selective indications for an ERRT first strategy in neonates with congenital kidney failure. And I'd just like to acknowledge the RAFT trial investigators and funding support, especially the late Eric Jellin, who was the pediatric surgeon at a force behind the RAFT trial and a real champion for patients with fetal renal failure. Thank you.
This paper is open for comments and questions. So I guess one question that I have, do you have any idea what criteria was used by these places and which method that they used? And what's the ideal patient for the ERRT first?
About 75% of the patients who received ERT first received Aqueducts. And there were differences between centers, even those who used Aqueducts, as to whether they used it for pure aquapheresis or for sort of modified hemofiltration or for some combination of the two. And we found that sort of anecdotally, centers seemed to change their practices the more patients they accrued. 9 centers and 32 patients. It's not like any of these centers has a huge experience. But I think centers were using their own historical experience with this population more necessarily than any specific criteria.
Hi, Yusuf Gohari, University of Missouri. During my training in Children's Nebraska, we moved away from offering hemodialysis because a lot of these catheters get clogged off and a circuit change and a lot of issues. So we moved to giving primary peritoneal dialysis, and we initiated dialysis about a week after placement. We did submit an abstract to discuss the result, but got rejected. But anyway, so we're advocating for primary peritoneal dialysis catheter placement for premature babies because of all these issues with the hemodialysis catheter placement.
Yeah, I think that's a good point. We are planning to look specifically at the incidence of occlusion and leak in the pheresis or hemodialysis catheters and PD catheters, respectively. The challenge with that is that the way that these data were collected for the purposes of the RAFT study, we don't have a good sense for sort of the number of days for which a leak was present or the degree to which an occlusion disrupted renal replacement therapy if there wasn't a catheter exchange. But I think the fact that a lot of these centers are using Aqueduct, sort of isolated aquapheresis with some success, which is associated with fewer catheter complications, less coagulopathy and inflammation, I think may suggest that that specific renal replacement therapy is a good bridging strategy to allow for better PD catheter healing and ultimately a more durable early chronic dialysis access.
In the interest of time, we'll move to the next talk. Thank you.
Thank you. The next presentation is entitled Patterns of Practice, Research, and Engagement in the First 10 Years of Practice, a survey of APSA early career pediatric surgeons, to be presented by Dr. Hamidi.
Good afternoon, everyone, and thank you for this opportunity. So we conducted this research because the APSA Board of Governors sought to understand the experiences, organizational engagement, and challenges faced by early career surgeons in the first 10 years of practice. The goal of this work is to characterize the evolving landscape of pediatric surgical practice in order to better understand the unique challenges faced by early career surgeons and how APSA can better support them. We distributed this survey to all APSA members. Participation was voluntary, and respondents had the option of whether or not to disclose their personal information. For this analysis, we focused on early career surgeons, abbreviated ECS, defined as APSA members who had graduated fellowship within the last 10 years. We further subdivided this group into early, or EEC, who have been in practice for 0 to 5 years, and late, or LEC, who have been in practice for 6 to 10 years. We had a 30% response rate out of a total of 333 early career surgeons. Half were EEC, who had been in practice for an average of 3 years, and the other half were LEC, who had graduated 8 years prior. EEC surgeons are slightly younger in age, and there was an even distribution of gender in both groups. We first looked at research involvement and found that early career surgeons are highly academic. Nearly all respondents participated in research during training, and the majority still do. EEC most commonly have less than 5 publications since graduating fellowship, whereas the majority of LEC have greater than 20. Breaking this down by publication type, we found that clinical outcomes, database studies, and retrospective reviews were the most common for both groups, followed by case reports and book chapters. There is a higher proportion of LEC involved in clinical trials, which may reflect the higher level of experience needed to conduct rigorous studies. We next looked at practice setting and found that the vast majority of early career surgeons are employed by urban academic hospitals. The majority of early career surgeons have academic ranks, and only 8% of new graduates are clinical instructors. By 5 to 10 years after graduation, there is significant career advancement, with nearly half of LEC promoted to associate professor. Early career surgeons are highly ambitious, and more than half of both the early and late cohorts hold leadership roles at their institutions. In terms of practice volume, most early career surgeons work an average of 60 to 69 hours per week. Even while working the same number of hours, LEC surgeons perform 50 more cases per year, which may suggest increased referral volume and improved efficiency over time. We then turned our attention to APSA participation and found that engagement is high among early career surgeons. 2/3 report either presenting or having a mentee that has presented in an APSA meeting, and almost half have participated in roles other than presenting. Interest in service and leadership within APSA appears to wane over time. We hypothesize that this finding could, at least in part, be explained by increased leadership involvement in other forums, as nearly all early career surgeons were dues-paying members of at least additional society. However, further investigation is needed. 75% of our cohort reported experiencing challenges in the first 10 years of practice, and these obstacles appear to significantly decrease over time. Overall, work-life integration and call burden were the most common obstacles faced by early career surgeons. However, EEC reported more difficulty with finding senior mentors, the practice of surgery, and becoming a parent, whereas more LAC faced concerns about care of aging parents and marital stress. More than half of respondents reported that APSA could do more to address early career surgeon career priorities, including contract negotiation, career mentoring, and improving or maintaining operative skills. Respondents were given the opportunity to answer this question in their own words, and a few interesting themes emerged, including ECS inclusion and empowerment within APSA, supporting ECS in a variety of healthcare models and communities, and mentorship focused on research, navigating healthcare systems, and balancing priorities. In conclusion, early career surgeons are highly academic and take on institutional leadership roles early. They are highly engaged with APSA, and the majority desire ongoing involvement. However, interest in leadership positions wanes over time. Major challenges include work-life integration, surgical practice, and mentorship. APSA should address contract negotiation, mentorship, maintaining operative skills, and empowerment within the organization. Limitations of our study is that it is a small cross-section of a larger cohort, and because the responses were binary, we're unable to assess the relative burden of individual challenges. In the future, we hope to implement APSA programming to specifically address early career surgeon concerns and assess their efficacy. We also hope to continue to perform these surveys of new graduates and follow up with previous respondents to see how these responses evolve over time. Thank you, and I'm happy to take any questions.
Paper is open for questions. I'll take a moment and make a comment, and that is that I hope there are members of the APS TPD, and specifically the Transition to Practice Subcommittee, in the room listening to this. I imagine that your data will heavily inform how they work moving forward. Can you propose, we've heard a lot in the last few days about APSA's new initiatives. Can you think of creative other ways that APSA can better serve early members?
I mean, it's hard for me to say as a resident, but I think a lot of especially the free text responses for this survey were very illuminating. I think some of the main themes that came forward were that early career surgeons are really excited to be involved and kind of perhaps have the opportunity to do things in new and interesting ways and have their voices be heard more rather than, taking more of a look and listen approach. So I think that empowerment and inclusion and valuing all types of voices would be really exciting. Thank you.
Thank you.
Our next paper, Current Practice Patterns and Outcomes Following the Ingestion of Water Beads in Pediatric Patients, a Pediatric Surgery Research Collaborative Study, presented by Dr. Jennifer Hsu.
Good afternoon, and thank you for this opportunity. This research was inspired after an 8-month-old male presented to our institution with a small bowel obstruction from water bead ingestion. 4 expanded beads were removed with an exploratory laparotomy, but after he failed to progress, he required an additional laparotomy for retained water bead, causing a repeat obstruction. At nearly the same time, our surgeons took care of a patient at a satellite institution with a virtually identical story, who also required 2 XLAPs after ingestion. These patients inspired us to examine current practice patterns after water bead ingestion, which are important to understand in order to inform clinicians and improve patient treatment outcomes. Water beads are small, superabsorbent polymer beads that are designed to absorb water and expand. They're marketed for a variety of purposes, including as toys, and they're often multicolored, looking like candy to small children. Since 2020, the number of emergency department visits for water bead-related injuries has been dramatically increasing, more than tripling from 2020 to 2022, according to national surveillance data. However, no protocols for water bead ingestion have been published, and minimal data exists regarding current management practices. The Pediatric Surgery Research Collaborative therefore designed and implemented a study to ascertain the current practice patterns and outcomes following water bead ingestion. In addition to describing the presentation, clinical course, and outcomes, we aimed to distinguish an age group at increased risk of obstruction and describe the management strategies that may decrease the risk of repeat surgeries. We conducted a retrospective review, including data from 13 centers. All suspected or witnessed water bead ingestions were included. Charts were analyzed for the highest level setting of encounter, patient age, symptoms, imaging, comorbidities, treatments, and outcomes. A total of 280 patients were identified. The mean age at the time of ingestion was 29 months. Median time between ingestion to presentation was 2.5 hours. Most patients were evaluated in the emergency department. 24 patients had telephone encounters, 12 were seen in urgent care, and 5 had office visits. 68% were asymptomatic. The most common symptoms were abdominal pain and vomiting. 66% of children had x-rays taken, 21% had ultrasounds, 5% had CT scans, and 29% had no imaging. 8% of x-rays, 20% of ultrasounds, and 46% of CT scans successfully depicted at least one bead. Laxative administration was the most common non-procedural intervention at 7%. 22 children, or 8%, underwent upper endoscopy alone. 3 of these patients had water beads visualized, and 1 patient was able to have the beads entirely successfully removed with endoscopy. 1 patient underwent initial laparoscopy alone, and 7 underwent initial laparotomy in their index procedure. Of the 90 patients under 22 months, 8 patients, or 9%, had a bowel obstruction requiring a laparotomy. 3 required repeat laparotomy for retained water beads, causing recurrent obstruction. The median age of children requiring surgery was 14 months. This figure represents the anatomic locations where the beads were found at the time of surgery. Each color represents a different patient, and the numbers indicate the number of beads found. The terminal ileum was the most common location of obstruction. Water bead ingestion is becoming more frequent. This problem is a unique issue, with the expanding foreign bodies posing diagnostic and therapeutic challenges, and may require repeat interventions. X-rays and ultrasounds can be used for the detection of intestinal beads but are not reliable. Laxatives may not be effective. Endoscopy has demonstrated efficacy in some cases. Older children may be less prone to obstructing from water bead ingestion. Specifically, those under 22 months old are at highest risk of an operation. There are no consensus guidelines for dealing with water bead ingestion. By exploring the experience of water bead ingestion multi-institutionally, we are moving the needle of understanding of the problem and working toward better solutions for our patients and their family, paving the way for an evidence-based treatment guideline. Thank you, and I'm more than happy to entertain questions.
This paper is open for questions. While people potentially go up to the microphone. So I noticed from your data that not everybody needed an intervention, either non-operative or operative. So of those children that didn't have anything done, were they observed? Do you have any data on how long that was felt to be safe to observe them and what happened when they went home?
Right, thank you for that question. The data does include all suspected or witnessed ingestions, so it is heterogeneous in that not everyone who presented had a known ingestion. As you pointed out, the good majority of the patients that were in our sample did not need an intervention, especially some of the older patients. I think as water bead ingestions become more well-known, parents are also having a lower threshold of concern to bring their child in, which is good. Not everyone was admitted, and not everyone was even observed in the emergency department in our sample. So several patients had initial imaging or no imaging and were sent home.
Do you know if anybody bounced back?
None of the patients that were discharged from the ER came back.
Yusuf Gohar, University of Missouri. I just would like to applaud the authors for doing such a study. We had an identical case in Omaha, a child, an 8-month-old, who swallowed such a bead, and then the mom gave an interview to the local news network to try and increase awareness of other families about the dangers of the water beads. Just like we have these increased education for button batteries, I think there should be more education about these water beads as well. Thank you.
Thank you for that comment.
So we actually put a BPA for our EPIC that for swallowed items that reminds people the number for the U.S. Consumer Product Safety Commission. So it pops up and reminds people to report these items. I do encourage people, if you have a patient that comes up, just send them an email, write them a letter. That's one of the things that we've done for batteries that help for the battery packaging, and I think it'll help with these products, but this is a fantastic paper. Thank you very much for it.
Thank you for that reminder, and as a reminder, clinicians can also submit those reports.
Sorry, Sid Johnson, Honolulu. It's probably a stupid question because my kids have grown older and they don't have water beads and I don't play with them at home, but I'm curious about those who have given laxatives. Do they actually shrink if you put a bunch of Miralax in there, or do we know this?
So we don't have in vivo data. Our lab separately did a different study where we looked at the beads in a variety of different solutions, and they do grow in Miralax, and that is published. So we would advise using caution if you are planning to administer Miralax, because they do grow.
Thanks, that'll make it so I don't have to do this study at home.
Thank you.
The next presentation is entitled A National Database Study of Adjuvant Steroids Following Kasai Portoenterostomy for Biliary Atresia, to be presented by Dr. Liang.
Are the slides up? I don't see them.
It's the green button.
Try the green button.
Sure. Great. Thank you so much for the privilege of the podium. I have no disclosures. Biliary atresia is a fibro-obliterative disease of the extrahepatic biliary tree that involves progressive intrahepatic fibrosis. The standard of care involves Kasai portoenterostomy, but even with successful biliary drainage, the majority of these patients go on to require a liver transplant in their lifetime. Steroids have been commonly used in the postoperative management of Kasai in Europe and in Asia, but currently the role of postoperative steroids in the US remains controversial, with a handful of cohort studies and RCTs that have demonstrated conflicting results with respect to their purported benefits. Thus, the objective of our study was to characterize variations in inpatient steroid use after Kasai and investigate the association of steroid use and native liver survival in a large multi-institutional cohort of biliary atresia patients. In order to perform our study, we queried the FIS database for all patients who underwent Kasai for biliary atresia between 2017 and 2024 at pediatric liver transplant centers. We excluded hospitals that did not perform pediatric liver transplant, and we also excluded study sites that did not participate in FIS for the duration of our study period. Patients were defined as having received adjuvant steroids if they got at least 1 dose of steroids in the 7 days after their Kasai. And then our primary outcome of interest was native liver survival. This was defined as the total time without a liver transplant, and we abstracted this data by pulling readmissions with ICD codes for liver transplantation. Additional secondary outcomes that we also looked at were 30 and 90-day readmissions, both overall and due to cholangitis. So we looked at the baseline characteristics for our cohort. This included 504 patients from 37 hospitals. 276 of these patients received no steroids, and 228 of these patients did receive adjuvant steroids. We did not see any statistical differences between their baseline demographics. We did note that patients who received post-op steroids were more likely to have a longer length of stay. And we also saw that patients treated at a higher volume Kasai centers were also more likely to receive adjuvant steroids. With respect to their postoperative outcomes at 30 and 90 days, we did not observe any statistically significant differences in readmission rates. We did note a potential increased trend in 30-day overall readmission in the adjuvant steroid cohort, though again, this was not statistically significant. And at 90 days, there were more patients who were readmitted specifically with a cholangitis diagnosis in the non-steroid cohort, though also not significant. For the next part of our study, we sought to characterize inpatient steroid use after Kasai for the 228 patients who received adjuvant steroids. So we saw that the majority of patients who did receive adjuvant steroids were started on the day of their operation. And then we also looked at the median duration of inpatient adjuvant steroids, which was found to be 5 days with an IQR of 1 to 8 days. And we further stratified these data by hospital to examine differences in duration of steroid utilization by study site. On the y-axis are individual de-identified hospital IDs, with each box and whisker plot representing one hospital site. On the x-axis is represented the total number of adjuvant steroid days that they received. And then hospitals that gave steroids to fewer than 2 patients were excluded from this particular plot, but not from our analysis. So as you can see, the majority of study sites that did use adjuvant steroids used a pretty tight range of steroids, except for the one outlier that you see at the very top. Next, we examined native liver survival at 6 months, 12 months, and 24 months after Kasai. We did not find any statistically significant difference in native liver survival between either of the cohorts. Finally, we used a Cox proportional hazards model to further examine the effects of adjuvant steroid use and additional covariates on native liver survival. For our adjusted analysis, we demonstrated that age greater than 2 months at the time of Kasai consistently predicted reduced time to liver transplant, which has been previously shown, and we do know this from prior literature. We did see no association noted for steroid usage or for hospital Kasai volume. And then of note, we clustered for a hospital site in order to account for unmeasured site-level confounders. There are some limitations to our study. First, in order to use FIS to study steroids and the correlation with native liver survival and biliary atresia, we had to limit our analysis to only pediatric liver transplant centers. This method assumes that patients who underwent Kasai at one hospital would be readmitted to that same hospital to undergo liver transplant, and it obviously does not capture any patients who are transferred outside of that hospital system. Second, this is an administrative database study, so we have limited data granularity, and we can only show correlations. And finally, it is possible that a patient who did not receive inpatient steroids was started on steroids in the postoperative setting, and this may also affect their native liver survival. So in conclusion, adjuvant steroid use is associated with increased length of stay and increased Kasai volume. The majority of FIS hospitals that did use adjuvant steroids were noted to start immediately and with a very short, relatively short range. And finally, there was no statistically significant difference that could be found in native liver survival up to 2 years with adjuvant steroids after Kasai in a large multi-institutional biliary atresia cohort. Thank you. I especially want to thank my co-authors, particularly Hamza Thobani, who performed all the statistical analyses. I'm happy to take any questions. Thank you for your attention.
paper is open for questions. And while people are coming up to the microphone, if I understand the data correctly, despite the fact that we worked very, very hard to run a randomized controlled trial of this very question, right now in 2025, about half of the people are getting steroids and half are not.
That's correct. And I think a lot of that is based on studies coming out of Asia and in Europe. And in 2023, there was a randomized controls trial that came out in Annals of Surgery from China that demonstrated a native liver survival benefit for the use of steroids. So I think a lot of people are still using steroids, clearly.
Can you comment, and are some of those prior trials underpowered to detect a difference that you think exists based on your data?
I think that was the initial reason why we undertook the study. The START trial, I think, had like 140 patients. I don't know the details of the powering, but the Chinese trial had over 200 patients, and I was thinking maybe if we could expand the number of patients included in our cohort study that we could potentially see a difference.
Did you look at rates of cholangitis between the two groups and the dose of steroids?
Yes, we did look at rates of cholangitis. We specifically looked at cholangitis, readmission with cholangitis at 30 days and 90 days, but we did not look beyond the 90-day mark.
Thank you very much for your presentation.
Thank you.
All right, our next talk seemed to be getting all of the things that shouldn't be swallowed. So the next talk is Assessing Process Measures and Practice Variability in Pediatric Button Battery Ingestion, a Multi-Institutional Cohort Study, presented by Dr. Anusha Motoro.
Hi, everyone. Thanks very much for the opportunity. In the US, it's been estimated that every 75 minutes, a child presents to the ED with a battery-related complaint. An esophageal button battery is a life-threatening emergency that can cause severe esophageal injury in as little as 2 hours. And national management recommendations include rapid removal and intraoperative mitigation strategies like sterile acetic acid irrigation. But large-scale tracking of compliance with these guidelines is challenging for a number of reasons, including that they're rare events, and until recently, there weren't great ways to identify cases using billing codes. Without this large-scale data, it is a challenge to study esophageal button battery management and where there may be opportunities for improvement across hospitals. Recognizing this, the National Surgical Quality Improvement Pediatric began voluntary collection of esophageal button battery variables as part of collected data on process measures. Using these data, our study aimed to identify areas of practice variation and opportunities for care standardization in esophageal button battery cases. We used the NISQUIP pediatric database from 2021 to 2023 to study variation between hospitals in process measures of timeliness, perioperative imaging, and mitigation strategies using descriptive and univariate statistics. We also looked at the subgroup of patients who were transferred in to examine the effect of repeating imaging studies on the timeliness of care. Results reflected 86 patients across 28 hospitals who had an esophageal button battery, with hospitals sampling 1 to 10 cases over the 2-year study period. We next looked to see, in this broad sample of 28 hospitals, how fast are these patients getting into the OR? For these 86 patients, the median time from presentation to operation was 98 minutes, and the 75th percentile was just under 2 hours. The median duration of the operation we found was about 35 minutes. Next, we looked at our subgroup of the 52 patients who were transferred to the NISQUIP pediatric institution with imaging already performed at the outside institution. Just over half of patients had diagnostic imaging repeated, and presentation to the OR was significantly shorter for transferred patients who didn't have their imaging repeated. This may seem sort of like an obvious takeaway. If we add a step, it's going to take longer to get the patient into the OR, but particularly for these time-sensitive operations, every minute counts. And these data show that just getting a repeat chest x-ray adds a median of 30 minutes to getting patients into the operating room. Moving from the pre-op phase to the intra-op, the op notes documented use of sterile acetic acid irrigation in 70% of cases, and only 45% documented adequate use of over 50 mils of irrigation. Moving to post-op, 72% of patients had a post-op esophagram. and the timing of these studies ranged anywhere from less than a day to 6 days postoperatively. Roughly half of the hospitals had both cases with and without postoperative esophagram. And for us, this just highlighted that the timing and utilization of postoperative esophagams are a potential opportunity for care standardization. This study has limitations, including that data submission was voluntary, and there were very limited variables collected, which precludes our ability to account for injury severity or incorporate any rationale behind clinical decision-making. Also, this study may not be generalizable beyond the NISQUIT pediatric institutions sampled. A few key takeaways we want to end with. We found opportunities for care standardization in a few areas. First, there's opportunity to avoid unnecessary repeat imaging and transferred patients, as they were associated with meaningful delays and time to operation. Second, we can improve both utilization and documentation of using at least 50 milliliters of sterile acetic acid irrigation intra-op. And third, we have room to clarify the indications and timing for postoperative esophagams. We also just want to highlight the importance of cross-disciplinary efforts between clinicians, policymakers, and industry. Clinician advocates have collaborated with policymakers to establish the ICD-10 secondary diagnosis code W33A1 to facilitate research and regulatory efforts aimed at injury prevention. Also, Reese's Law limits children's access to button battery by maintaining child-resistant battery compartments, packaging, and improving warning labels. Similarly, there have been important industry innovations for novel safe button battery technology with surgeon champions, and 12 professional organizations, including APSA, have a position statement endorsing these efforts. I'll conclude with this educational image that we're probably all familiar with, especially residents, distinguishing button batteries from coins on chest x-rays. Everyone, please just take a look for a minute and decide which one is the button battery and which is the coin. Hopefully the image is coming through okay on the screen. The one on the left is a coin, and the one on the right is the button battery with the classic double ring or halo sign. Dr. Jatana, my advisor on this project, wanted me to remind everyone to always zoom in on the image and really get a good look at the item in as close as possible. Thanks very much.
Paper is open for questions.
Gilchrist, Brooklyn. I have a question for you. If a patient comes in and you're telling us not to get a repeat film, what if the battery's gone into the stomach and it's no longer in the esophagus? How do you handle that?
That's a fantastic point, and I think it kind of speaks a little bit to some limitations in the data that we have available. Because we had such a limited data set, we couldn't include factors like clinical decision-making behind why a clinician may repeat that imaging study, and of course that seems like a very reasonable reason to get a repeat chest x-ray to see if it's moved.
Hi, Scott Short, Salt Lake City. I more have a comment. One of the things we did to address delays in getting these children to the operating room in our facility was actually tying this into our trauma system. So when these kids hit the ER, there's actually a page that goes to the attending surgeon. It's a level 1 button battery alert, and it immediately activates a series of things that have to happen. Oral sucralfate, the attending surgeon gets called and looped in immediately. And so it really helps abbreviate these time delays, and we actively track it and review all those cases. And we're, in most cases, able to do this in roughly 30 minutes. So just as people think about how they want to tackle this.
Thank you.
Yeah, I'm going to add a little bit to that because I think we all think of button batteries as an emergency, but I think there's two categories of the button batteries. There's the witness button battery, and you know the time, and those are the ones that we treat as an emergency. And then there is the group that we don't know the time, or we have a time that's greater than 4 hours. And in those situations, it should be completely treated differently. You do give the honey, you do give the sucralfate, you do all that stuff at the outside hospital, but when they transfer in, you have to do imaging to make sure, you have to do labs to make sure that they don't have a sentinel bleed, they don't have a low hemoglobin, and you do imaging to make sure that the vessels around it, there's no erosion into the vessels. Because it's not unusual to get erosion into the vessels and have deaths. And in fact, there's some institutions that are doing repeat MRIs on these kids after they do this to make sure that there's no delayed erosion. And we're doing CT angios on the kids before for unknown period of time in 4 hours, because we have had deaths because of that.
A couple of process measures that maybe we're good looking forward as well here with my airway hat. airway evaluation, particularly if the lateral film showed the step-off, the negative pull facing anteriorly, that kid's high risk for a TEF or a fistula to the airway, and also recurrent laryngeal nerve injury, so vocal fold movement impairment. A lot of these kids end up with aspiration, respiratory infections because nobody checked their vocal cords. But the other thing is, I still think even if it went to the stomach, you still are it's a good idea to look, because sometimes it did spend a good amount of time in the esophagus, so I don't know. I mean, I think it's a good discussion point to have whether because we treat them like a level 1 trauma and go to the OR, even if they've had 4 hours, 6 hours, 8 hours, we get the imaging afterwards. You are prepared to get all those additional things in the OR. It's kind of, I do think time is sensitive, even if it's been there for several days.
All right, in the interest of time, we'll move on. Thank you.
We'll move to the presentation S20, which is potential risk of missed diagnoses when choosing non-operative management in pediatric uncomplicated appendicitis. Is it worth it?
Thank you very much for the opportunity to present today. Figure this out.
Try the
green button.
Green button. There we go. Thanks very much. I have no disclosures. While appendectomy has historically been the standard treatment for pediatric uncomplicated appendicitis, non-operative management has been proposed as an alternative to surgery. Pros of this approach include fewer disability days and the avoidance of surgical risks, while a well-established con of this approach is a high failure rate, with up to 30% of patients who initially undergo non-operative management eventually needing surgery within 1 year. A less well-known potential drawback of this approach is risk of misdiagnosis, so we sought to quantify the potential risk of misdiagnosis when choosing non-operative management for pediatric uncomplicated appendicitis. We also sought to assess our perioperative outcomes. This is important because further understanding the risks versus benefits of choosing non-operative management aid our ability to effectively engage in shared decision-making with our patients and their families. To do this, we performed a single institution retrospective cohort analysis, including pediatric patients who had an appendectomy over a 5-year period from 2019 to 2023 at our institution for a diagnosis of uncomplicated appendicitis. We used a postoperative length of stay of less than 48 hours as a surrogate for uncomplicated appendicitis, consistent with our institution's management protocol. We excluded patients with complicated appendicitis, those who had an interval appendectomy, those whose indication for surgery was not acute appendicitis, and those who had an incidental appendectomy as part of a different surgical procedure. Our primary outcome was pathologic diagnosis, which we categorized as non-perforated, perforated, infectious, neoplastic, and normal, which is a negative appendectomy. Our secondary outcomes included length of stay, EC returns, readmissions, and then the need for additional procedures following the appendectomy. In total, nearly 8,000 patients underwent appendectomy at our institution over the 5-year study period. We excluded approximately 2,700 of these patients per our criteria, giving us a study cohort of 5,233 patients with uncomplicated appendicitis, or 65% of all appendectomies at our institution. The average age of our cohort was 12 years. Patients were more frequently male at 61%, and the median postoperative length of stay was 2.6 hours, while the majority of patients presented through the ED at our institution, just over 30% were transferred from outside hospitals for surgical evaluation. For a pathologic diagnosis, 97% had routine appendicitis, of which 118 were found to be perforated on pathology review, and thus managed in discordance with their presumed diagnosis of uncomplicated appendicitis. 24 patients, or 0.5% of the cohort, had infectious organisms on pathology, the most common of which was Enterobius vermicularis. 31 patients, or 0.6% of the cohort, had neoplasms on their pathology, the most common of which was a neuroendocrine tumor, although there was also one mucinous neoplasm and one lymphoma. And finally, 98 patients had a normal appendix on pathology, for a negative appendectomy rate of just below 2%. For our outcomes, 240 patients returned to the EC for a return rate of 4.6%. 71 patients were readmitted for a readmission rate of 1%, and 17 patients required additional procedures, the most common of which was IR drainage of abscess. So in conclusion, at our institution, which is a high-volume quaternary care center in Houston, Texas, 1% of patients who underwent appendectomy for uncomplicated appendicitis had alternative diagnoses, including occult malignancies and infections. Perioperative outcomes are very favorable, with low rates of negative appendectomy, EC return, and readmission. And together, these findings reinforce appendectomy as our preferred treatment for uncomplicated appendicitis, but of course, shared decision-making should occur on a patient and institution-specific basis. Thank you very much for your attention. Happy to take any questions.
This paper is open for discussion. A room full of surgeons and no one has an opinion about appendicitis. I just wonder, oh, thank you.
Oh, sorry, I'll put you off the hook. Brian Gray from Indianapolis. Thanks for looking at that. That's an amazing number of patients, and I feel for all your surgeons who are doing those appendectomies. The interesting patients you mentioned are that 1% who had that malignancy rate. Can you comment if you looked back on the imaging at all to be able to tell whether or not there seemed to be a mass there? Because that would be a decision-making point if you see a mass or not in those patients. Thank you.
Thank you for your question. Those patients who had a mass on their initial imaging were not included in the analysis because then their indication for surgery would be not necessarily just acute appendicitis, but also the mass. So that would be a separate cohort from what we included in our study.
So do you use these findings in your counseling for families trying to decide on what course to take when they choose whether they want to do an appendectomy or non-operative management? And of the ones who may choose non-operative management, do you think most of these diagnoses that are other than appendicitis, they would end up coming back anyway?
Yeah, thank you for your question. I think that's a very good point. I think it's just another piece of data that you can present to patients and their families when you engage in shared decision-making. But also to your point, you can counsel them that if you have one of these alternative diagnoses, you could most likely return with persistent symptoms. The impact of waiting for surgery is not necessarily known. It could be, low risk to do so. Thank you.
Thank you.
The impact of Michigan Public Act 246 on opioid prescribing after pediatric surgery, presented by Dr. Ryan Davis.
All right. Well, great. Thanks for the introduction twice. And thank you for the opportunity to present our research. Unfortunately, the future Dr. Saunders was unable to be here. She's graduating from medical school today, so we determined that that was an acceptable excuse. So congratulations to Dr. Saunders. We have nothing to disclose. Opioid misuse is not limited to adults. It also significantly impacts our pediatric patient population. 1 in 4 adolescents are exposed to opioids before high school graduation, and surgical prescriptions are a key source of unused opioids. Up to 94% of adolescents will divert their medication if they are approached by someone familiar potentiating the opioid epidemic. Also, pediatric surgery prescribing practices do vary widely between providers and specialties. Michigan Public Act 246 was enacted June 1st of 2018 as a legislative combat to the opioid epidemic. This legislation requires face-to-face consent in a start talking consent form and requires signatures from the prescriber, minor, and guardian. The name and dose of opioid prescribed is also on the form, as well as a confirmation that a discussion took place. During this discussion, risk of opioid addiction and overdose is discussed, as well as the dangers of combining opioids with alcohol, benzodiazepines, or other depressants. You also need to discuss higher addiction risk in those with mental health or substance use disorders. There are exceptions, like emergencies or when legal guardianship is not established. For our study design, we aim to determine the effects of Public Act 246 on opioid prescribing at our institution. We conducted a retrospective single-center study at Corewell Health East Children's Hospital from 2015 to 2021. Our inclusion criteria included pediatric patients less than 18 years of age undergoing outpatient surgery who underwent the following procedures: inguinal and umbilical hernia repairs, adenoidectomy, circumcision, tonsillectomy, and tympanostomy. Our exclusion criteria included age greater than 18 years, patients with multiple simultaneous procedures, patients who had intraoperative complications, or patients who were readmitted or required secondary surgeries. We collected opioid data, including the medication name and duration, and converted that to morphine milligram equivalents, or MMEs. Our primary outcome was the change in MMEs prescribed pre and post Public Act 246. We did conduct 2 multivariate models that adjusted for age and insurance and was stratified by surgical specialty and procedure types. This is a busy slide, but I want to direct your attention that the study included 7,280 patients that were relatively evenly distributed between the groups. Prior to June 1st of 2018, you can see the male to female distribution is almost 2 to 1. Also, for the mean age, we had a 3.2 years of age and 3.1 years of age prior and after Public Act 246, respectively. The most common surgery performed prior to June 1st of 2018 was a tympanostomy at 25.5%. The most common surgery after June 1st of 2018 was 31.3% of circumcisions. And our pediatric ENT colleagues performed the most procedures both prior to the act and after. What I want to direct your attention to is this chart in the upper right-hand portion of the screen, which demonstrates the morphine equivalents prior to June 1st of 2018 and after. Prior, the mean across all surgical specialties and procedure types was 7.7 milligrams, and after was 3.2. This is a 4.5 milligram MME less after enactment of Public Act 246. We looked at the adjusted means for morphine equivalents by surgery type. As you can see here, the biggest decreases in MME were circumcision and tonsillectomies for adjusted morphine equivalents. All procedure types did see decreases in morphine equivalents. Of note, there was also statistically significant decreases in repairs of umbilical hernia and laparoscopic and open repair of inguinal hernias. We also looked into the adjusted means for morphine equivalents by each subspecialty. Our pediatric urology colleagues had the highest amount of MME prescribed prior to June 1st of 2018, followed by pediatric ENT and then our pediatric surgery colleagues. All 3 had statistically significant differences and decreases following the initiation of Public Act 246. We did also stratify the comparison of inguinal hernia repairs by surgical specialty. As you can see, our pediatric surgeons had a decrease in approximately 2.7 decrease in MME, both prior to June, when comparing prior to June 1st of 2018 and after, and our pediatric urology colleagues had a decrease of 4.6. It's also important to note they had a higher starting point than pediatric surgeons. Both of these these decreases in morphine equivalents were statistically significant. We also looked into the adjusted means for morphine equivalents by age for the 2 time points. The green line here just shows prior to June 1st of 2018, the average morphine equivalents prescribed to our patients, and then after June 1st of 2018 with the gray line. As we would expect, the morphine equivalents prescribed increases with age, however, it was significantly decreased following the act. Our study has a few limitations. One, it's a retrospective design, which limits the ability to infer causation, and the age range. The mean age was 3.2 years, so the findings may not be generalizable to older adults. We didn't collect any pain outcome data, but we did not assess pain scores or quality of life postoperatively, so we can't determine if the reduced opioids affected pain control either positively or negatively. Future directions at our institution may be implementing the comparison of opioid use with over-the-counter options like acetaminophen or NSAIDs. We could also evaluate age-related trends and potential prescribing bias. So to summarize our results, we included over 7,000 patients in our study, and children undergoing surgery after P246 were prescribed 4.5 milligrams MME less. General urologic and ENT procedures all showed significant reduction in MME. There was also significant decrease in MME prescribed for circumcisions and tonsillectomies. There was a significant decrease in MME prescribed for laparoscopic and open inguinal hernia repairs. So Public Act 246 in Michigan was significantly linked to a reduction in take-home opioid prescriptions for pediatric patients following minor surgeries. These results support the impact of guardian education and informed consent on prescribing behavior and also demonstrates how state legislature can promote opioid stewardship across multiple pediatric surgical specialties. So thank you for the time, and I'll take any questions.
Mohammed Amran, Corpus Christi. So most of us are using electronic medical records now to do our prescribing, our e-prescribing. Did y'all look at all at how many of the patients who had it prescribed actually got the prescription filled?
Yeah, so we weren't able to see if they filled the prescription, but we were, the way we stratified it was how much was prescribed initially by the provider.
And do you have any idea of what led to these changes that you saw? Was it a change in protocol caused by the law, or did people not want to comply with what the law was asking?
Yeah, there's several factors that we've discussed and tried to identify as other causes of why this could be the case. You know, with dual factor authentication in combination with another step that you know, residents and attendings have to complete before prescribing the opioids could all cause multiple hoops you have to jump through before you're prescribing the opiates, which could all cause an unwant to do that. So,
Elliot Pennington, Grand Rapids. There's been a nationwide trend towards prescribing less opiates. Did you compare this group in Michigan with another cohort that did not pass a similar public law? Thanks for this work.
Yeah, unfortunately, no, we didn't compare it to any other states. Right now, we're one of 8 states that has a specific legislature for minors and prescribing opiates. 32 states will loop it in under the adult consent form.
If there are no other questions, thank you to all the presenters for their excellent presentations. Thank you.
Thank you.